Okay, we now present the case which presented with the conjunctival laceration with the corneal abrasion. We had a 32-year-old male basketball player who was accidentally poked on the right eye by his friend player. The signs and symptoms with which he presented were the sharp pain, photophobia, the foreign body sensation in the eye, the tearing sensation in the eye, and the fiery red eye. And there was a staining of conjunctiva was seen, and the exposed white sclera can be appreciated, and the visual acuity of that patient was 20/40. And we did the workup with the slit lamp examination with the fluorescein staining positive, and we averted the leg to rule out any foreign body, and the treatment was started with the topical antibiotic coverage along with the artificial tears and the cycloplegics, and the patching was done for a good corneal epithelial healing because of the bandaging effect, and the repair of the laceration could be given, but not in this case was done because the laceration in this case was not so large, and we don't have to give to the steroids as it delays the repair of the epithelium. And the same patient presented 2 years later complaining of the throbbing pain and photophobia, though the visual acuity was improved. On the slit lamp examination we could see the cells and flare in the interior chamber. And the critical signs with which keratouveitis can present are the photophobia, either poorly dilating pupil or a large pupil, and the conjunctival laceration. And the workup of this patient after 2 days, what we did was the slit lamp examination and the IOP check, and the differentials with the differential of this patient could be either a corneal abrasion. It is still to be considered because he may not have used the patch, and hence there could be a delayed healing, and there can be a traumatic hyphema because of the tearing sensation and the fiery red eye, and it could be a traumatic iritis with which his signs, symptoms, and the presentation mostly matches. Therefore, hence we started a treatment with the topical cycloplegics, and we have to add on the steroids. There is no improvement in 5 to 7 days. And how do we follow up such patients? After 1 week, and discontinue the meds if all things are resolved, and check in 1 month for any post-trauma sequelae. This is the images showing the difference between the spontaneous subconjunctival hemorrhage and the subconjunctival hemorrhage due to the trauma. The spontaneous hemorrhage, subconjunctival hemorrhage is very little. It could be due to the heavy workload, or a Valsalva maneuver, or a cuffing. But this hemorrhage, extensive subconjunctival hemorrhage, is due to trauma. Seedles test is done to assess whether the perforation is leading to the leakage of the interior chamber, whether the interior chamber is leaky or not. The aqueous egresses out of the perforation, and this can be done. We apply the strip of the fluorescein on the cornea, and if there is a aggression the aqueous, we see this flaring up of the fluorescein from the perforated area, and after some time this aggression of the fluorescein will disappear because of the continuous irrigation from the aqueous which is coming out. If there is recurrent corneal abrasion due to these injuries, how do we treat it? We first give a trial of the hyperosmotic lubricant such as 5% sodium chloride ointment for about 8 weeks every night. And we can add on a bandage soft contact lens. If these are not working, we can do either surgically remove the epithelium by the epithelial debridement, or we can do the stromal micropunctures. If still these two out of either of two fail, we do the excimer laser superficial keratectomy so that there is an increased bonding between the epithelium and the Bowman's membrane. Next injury we see is the hyphema. What is hyphema? It is any gross blood in the interior chamber, and the micro means suspended amount in the aqueous humor. What are the signs and symptoms in the patient who presents with hyphema? It is pain and blurred vision. Visual acuity will be near about 20/80, and there is a gross blood noted on the interior chamber examination in the slit lamp. And how do we work up such patients? We ask about the patient about the extensive history, and complete ocular exam has to be done. How the closed globe trauma lead to the hyphema is that when there is an injury to the eye from an object, there is an equatorial expansion of the eyeball, and there is a retro displacement, that is the posterior displacement of the lens iris diaphragm. As the eyeball is elastic, this lens iris diaphragm will recoil back, but when it recoils, there is a tearing of the blood vessels in the iris and the ciliary body, which leads to the hyphema. How can the hyphema be graded? It can be a microhyphema, just the suspended particles in the interior chamber. It can be grade 1, 2, 3 and 4 based on the level the blood fills the interior chamber. The grade 1 25%, grade 2 50%, grade 3 75%, grade 4 100%. How do we treat the patient who presents with hyphema? We advise the patient the bed rest, the eye shield, and we do not have to press the eye during physical examination to avoid more bleeding. Long-acting cycloplegics have to be advised like atropine and homatropine. Mild analgesics can be given. Consider the steroids if the hyphema is also leading to, if you suspect iritis. Anti-antiglucoma drugs have to be given if the IOP is high, and aminocaproic acid has to be given if you think the blood will clot and will not be removed later on except from the surgical therapy. And we have to offer the supportive care by advising the patient to just have the moderate activity of sitting and walking and not anything heavier than that. Elevated head of the bed while sleeping to 30 degree, and the metal shield protection. Laboratory tests, the blood tests, the clotting test, that is the BT, CT, CBC, prothrombin time, platelet time, platelet count, blood urea nitrogen creatinine, that is the renal function test, the liver function test, and the electrolytes all have to be done. Also the sickle cell analysis using the sickle cell preparation or the hemoglobin electrophoresis has to be checked. What medications we have to use are the oral acetaminophen as needed. No aspirin or NSAIDs should be prescribed to such patients. Atropine 1% should be given twice daily in hyphema patients. Prednisolone acetate 4 times daily has to be given and increased as necessary. And oral M and aminocaproic acid should be started. What surgery we do if this hyphema is not resolving with the medical therapy? We use paracentesis and the AC washout for the IOP not responsive to the medical therapy within 24 hours. Only if the IOP is raised within, and paracentesis and medical therapy is not working for 24 hours, then we plan out surgery. Here this pic shows the rebleeding in the patient with traumatic hyphema, and this is the fresh blood having a level, and there a dark clot of the blood could be seen, and the corneal blood staining could be seen following the traumatic hyphema. When to admit for hospitalization? The hyphema patient has to be admitted in the hospital if he presents with a poor visual acuity, if there is any blood dyscrasias with increased IOP, if there is a medically uncontrollable IOP, if there is a large initial hyphema, if there is a delayed presentation to the ophthalmologist, if there is a large amount of recent NSAID intake. When do we have to follow up the hyphema patients? We have to closely follow up the patients which are at increased risk of rebleed, such as the sickle cell patients, and the golden period of rebleeding is 3 to 5 days after the initial bleeding, and hence we should keep the patient under observation for 3 to 5 days. We have to refrain the patient from any vigorous activity for about 2 weeks. Follow up in 2 to 4 weeks for a possible post-traumatic sequelae should be done. And what do we look in the follow-up? We look for the grade of the hyphema, and hence the initial grading of the hyphema becomes important, and yearly check should be done. What surgery? What are the indications for the surgery in a patient with hyphema? It is either the corneal stroma is blood stained, if there is a significant visual deterioration, if there is a total blood filling the AC, if there is a persistent clot packed in the angle, and if the IOP increases with maximal medical therapy, that is the intraocular pressure still increases even if we are giving the maximum medical therapy. Another presentation of the ocular trauma can be the iris can be lost due to the trauma. We can see in this case the aniridia due to a severe contusion. And how do we correct this aniridia? We use the iris print contact lenses outside iris print contact lenses, and this helps in a good osmosis and also helps sometimes in the visual acuity improvement. The next how the ocular trauma can affect the eyes in the form of trauma leading to the cataract of the lens. The traumatic cataract is secondary to the blunt or a penetrating ocular trauma. It can be in the form of a stellate, that is a star-shaped, or a rosette-shaped posterior axial opacities that may be stable or progressive. Lens dislocation and subluxation are commonly found in conjunction with this in conjunction with the cataract. The lens trauma can be either there can be a IOL in the pseudophakic patient, and this IOL, artificial IOL, may break either at the haptic or the optic or at the haptic optic junction. We have to look for the clarity. If the lens is crystalline or natural, we have to look for the clarity. And if there is a cataract with swelling, or if there is a cataract with no swelling, that is no intumescence. If the crystalline lens, also we have to look at the slit lamp for finding any capsular breach for any intraocular foreign body or any fragmentation. If the artificial IOL or the natural crystalline lens dislocates, we have to look for the subluxation or the dislocation of the lens, and the dislocation of the lens can be into the interior chamber, into the out of the eye, or into the posterior chamber. What are the signs and the symptoms of the traumatic cataract? It all depends on the mechanism of injury, whether it is a sharp versus blunt. The past ocular history of the previous eye surgery, glaucoma surgery, or any retinal detachment or the diabetic eye disease has to be taken. The past medical history of the diabetes, sickle cell, Marfan syndrome, homocystinuria, hyperlysinemia, sulfate oxidase deficiency should be asked to the patient. What are the visual complaints of the traumatic cataract patient? He or she presents with decreased vision. There can be a monocular diplopia, especially in an intumescent form of cataract or in an incipient cataract. Binocular diplopia could be seen if it is a long-standing case, and pain, either due to IOP rise or because of the initial injury. We have to follow the complete ophthalmic examination of such patients. We have to look for the afferent pupillary defect, if there is an optic neuropathy or not. Extraocular motility has to be seen to rule out any traumatic nerve palsies. Intraocular pressure to rule out secondary glaucoma or retrobulbar hemorrhage. In interior chamber, we have to look for the hyphema, iritis, shallow interior chamber, iridogenesis, and the angle recession. The lens has to be seen whether it is subluxated, dislocated, and whether the capsule is integrate or not. And what is the extent and the type of the cataract swelling, if there is any movement of the natural lens or the IOL, or that is the phacodonesis. If the vitreous is clear, or if there is a presence of a hemorrhage or PVD. Fundus, we have to look for the retinal detachment, choroidal rupture, any commotio retinae. Intraretinal hemorrhages, subretinal hemorrhages, optic nerve pallor, and optic nerve avulsion. This is the patient with a traumatic cataract or because of the penetrating trauma. Why penetrating? Because we can see the iris also avulsed from the ciliary body here. Okay, if the lens is dislocated into the posterior chamber, we can use the high liquid perfluorocarbons to levitate the lens, and then viscoelastic, and then fragment from this lens and get this lens out. What are the workups? We should do the B scan if the posterior pole cannot be visualized, and the E scan prior to cataract extraction and calculating the IOL power. The CT scan of the orbit helps to delineate any fractures and the foreign bodies. So the traumatic lens opacity is present. If it is severe, we have to remove it, or if the lens is failed, we have to remove it. And if it is mild, we can leave the lens and clean the AC as appropriate. If the posterior capsule is intact, we can go for phacoemulsification or ECC. If it is not intact, we should go for a vitrectomy probe or ECC. Whether to implant the IOL, it will depend on whether the retinal injury is present. If the retinal injury is not present, we can consider the implant if the condition is optimal. If the retinal injury, we don't know the status, do not implant. If the retinal injury is present, if there is severe or proliferative vitreoretinopathy, do not implant. If the PVR is minimal, implant if the condition is optimal. What are the treatment? If the glaucoma is a problem, control the IOP first with the standard medications, add corticosteroids, and the focal cataract can be observed, and miotic therapy may be of benefit. In some cases of subluxation, miotics may correct the monoocular diplopia, and mydriatics may allow for vision around the lens. For